Hi everyone, and welcome back to Money Power Health. As we've been discussing in previous episodes, health is to a large degree shaped by our social and physical environments. Public health has been defined by Acheson as the science and art of promoting health, preventing disease, and prolonging life through the organised efforts of society. Some of that art and science, in fact a lot of it, plays out at the local level rather than at national government. In the UK, local authorities have statutory public health responsibilities that are carried out by teams of public health professionals led by a director of public health, who is responsible for determining the overall vision and objectives for public health in the local area. What's so fascinating to me about work in this setting is that it's at the coalface when it comes to money and power. DPHs and their teams have to work alongside a range of other local stakeholders and elected councillors who change over time. For many of them, health might be a secondary concern, or not even something they consider themselves affecting. The skills that public health teams apply in managing this tension are unique, but incredibly important for many of us who care about money, power and health. This week, we're talking about the practice of public health in local authorities with Greg Fell. Greg Fell is the Director of Public Health of Sheffield and the Vice President of the Association of Directors of Public Health for the UK. During the COVID-19 pandemic, DPHs like Greg and their teams faced enormous pressures in terms of their capacity, coordination, expertise and media presence. Greg is a leading voice in UK public health and has an excellent blog where he pulls together a wide range of knowledge into bite-sized, actionable chunks. I'm a big fan. I'll put a link to his blog in the notes. It's really quite something. I hope you enjoyed this conversation with Greg. I certainly learned a huge amount from it. Greg Fell, hello and welcome to the podcast.
Morning, Nathan. It's a pleasure to be here and an honour that you want to talk to me.
No, it's the pleasure is mine. I'm really excited to speak to you both about public health in the UK in general, your reflections on being a DPH during COVID, and then talking a little bit about your thoughts on the intersection between money, power and health and how that applies to the commercial determinants of health more specifically. But I thought it'd be really interesting to start by asking you how you got into public health in the first place.
So, like I think almost all public health professionals I know kind of fell into it by accident. I don't know anyone really that finished school and said, I want to be a public health professional. We all fell into it by accident from various other career paths. So for me, did a science degree, did biochemistry degree many moons ago, and got to the end of that. I'm not sure I want to work in a lab, and I'm not sure I want to be a science teacher, and I'm not sure I want to work in the pharmaceutical industry. What should I do now? And by hook, crook, and some serendipity, ended up working for Hull University doing some work around smoking in pregnancy and alcohol drug use in pregnancy, just a smallish bit of social research. From there, got into what was then called health promotion, and basically had a long career in lots of different bits of public health, till I eventually got to do the public health training scheme in the UK, and then finished that, was a public health consultant and then a DPH in Sheffield.
And tell us a little bit, I guess, first of all, about, because you've been a DPH in Sheffield for a few years now, tell us a little bit about your patch in Sheffield, and then what it is that a director of public health does in that kind of setting, what you do day to day, and what your team does.
So about 7 years, which is a frightening amount of time. So the Sheffield patch, it's a reasonably big core city, north of England, about 560,000 people, maybe a few more than that. The census will tell us. It's a divided city, so health-wise, it's a sort of a fairly divided city. Most cities, most patches are. So for Sheffield, it's east-west. We all know health is socially patterned, and the most affluent part of the city is the west of the city. Accordingly, life expectancy and healthy life expectancy is much longer in the west of the city than the east of the city, which is much more socioeconomically deprived. So, that plays out in all of the health stats and all of the health metrics, however you want to cut those. Not just geography. Health also splits by ethnicity, it splits by disability, it splits by those who have a serious mental illness versus those who don't. And obviously those things are more evenly spread. But the defining feature is the gap in health for those that have and those that don't have. It's a big student city as well. So 60,000 plus students in Sheffield. So, almost 10% of the population are students who, as a rule, are spectacularly healthy, which is good. And for Sheffield is blessed that we have the highest retention rate for students, i.e. people do their degrees and then stay on, live in Sheffield. So it's a pretty vibrant city and it's a fairly young city. Public health wise, so what do you do then is the question that every director of public health hates being asked in the pub. But broadly speaking, there are 5 or 6 things within the job. Health promotion, which covers everything from tobacco, alcohol, gambling, food, weight, obesity, nutrition, right the way back upstream to the things called the social determinants of health: air quality, poor quality housing, poverty, low income, etc. And those things fundamentally shape and determine health. All of those things are within health improvement. Some of those things I'm very directly responsible for. Nobody's interested in tobacco other than me and my team. Poverty, I contribute to a wider party. So second bit of the job is health protection. So vaccination, screening, communicable disease outbreak control. And there's been quite a big one of those over the past couple of years. You'll have noticed. I think everyone noticed. Very occasionally, chemical and or radiological incidents. Greg, the chemical factory's on fire. There's a big plume of blue smoke hanging over this suburb or that suburb. What should we do, please? And very, very, very occasionally radiological stuff. So the early phases of the Litvanenko affair, it was the then Health Protection Agency that did the medical detective work. What is it? Where is it? Where is it coming from? And how do we put a stop to it? So that's within that box. Healthcare, public health, we still have a big role around providing advice and support to NHS and social care commissioners on how many hospitals we will need in 20 years' time. Should we or shouldn't we spend a large sum of money on drug X to treat 3 people that then comes with the opportunity cost of less resources elsewhere? So applied demography, applied epidemiology, applied health economics, etc. There's the responsibilities of the public health grant. So there's a bag of money that pays for services that do amazing things day in, day out across the city of Sheffield and every other local authority area. Health visiting, school nursing, sexual health services, drug and alcohol treatment services, tobacco control, including smoking cessation, weight management, and then other. And other is a really interesting category which covers a whole range of different things. A peculiar example is Sheffield Public Health is the main funder of Sheffield Citizens Advice Bureau. So money in pockets matters to health, matters enormously to health, as I think is fairly well evidenced. CAB do a very, very good job at maximising income for those people who have very low income. So I'm very pleased to say that we're the main funders of that. And that's in the other category. Next job is the health intelligence. How healthy is Sheffield? How do we know? What does the data and the stats look like? And there's a small team of people that pull all of that together. And then the last job of the DPH is pulling all of that together into a coherent whole. What is the strategy for health? By health, I mean health. I don't mean healthcare. Healthcare is important, mighty important, but health is much, much bigger than healthcare. So all of that together is what constitutes the job of the DPH and her or his team. Let's not forget the team bit there. And for me, the team is about 25 people. So the job is stitching all of that together into a coherent whole. And that's why I hate answering the question, so what do you do then?
Well, that was a brilliant answer, I have to say, Greg. Well done. And yeah, stitching it together seems especially difficult when so many aspects involve stakeholders well outside healthcare and public health. And I thought you gave a really fantastic example. I had no idea about the Citizens Advice Bureau. What an amazing intervention. Yeah. I could totally see how paying that puts more money in pockets, which then leads to a reduction in health disparities. I mean, it's seemingly so obvious, but at the same time, not what we might consider a health intervention traditionally.
Nightmarishly difficult to actually measure the health impact
Yes.
of putting money in pockets. People want to know, how does this... I don't think you can measure it. So we act on faith there, and I'm very happy to keep the faith, because it really, really matters. And at CAB and other similar advice services out there, they do an amazing job day in, day out. Particularly important at a time of a cost of living crisis, when people's pockets are very, very, very pressured.
No, I agree, and you're also right on measurement. This is something we talked about in a previous podcast with Salma Abdallah, about when we're talking about social determinants of health and how they influence decision making, not becoming prisoners of the proximate, when what we focus on most is what's most easily measurable versus what's potentially most impactful, or what contributes to both health but also wider well-being, wider quality of life.
Agreed completely. How one measures well-being, it's a tricksome.
Exactly. But it's nevertheless hugely important, right? I mean, after all, health is a means to an end.
Yeah, agreed. That was a point made in one of your previous podcasts. I forget which one, and I took that one to heart, and that made me think really deeply that we public health professionals need to be really, really careful about sort of health imperialism. Health is the only thing that matters. It's the end point that matters, and it's the ability to live the life that we want to lead that really matters. Health is clearly very important for that, but it's not the end in itself. No,
absolutely. And I guess this leads on to a question I've wanted to ask you for some time, which is, because success at the local government level is defined by so much more than just health. You have such a wide range of stakeholders. You have elected officials, fire services, police, health services, social services, right? Like local government deals with a huge range of things, all the way down to the arts and local education initiatives. And when I think about the definition of public health, I think of the Acheson definition, that it's about the art and the science. And it feels to me that you've talked quite a bit about the science, but a lot of what public health at the local authority level is about is the art of working with such a broad range of stakeholders, and in respectful ways, in constructive ways, and at times, reminding people of the health impacts of these wider areas. Could you speak to that sort of function, that aspect of your job a little bit?
Definitely few things. The sort of the textbook definition of public health, the one I frequently use, is the one that the Faculty of Public Health publish on their website, and I might get it wrong, and I may get struck off for getting it wrong. Sort of the science and art of improving health through the organised efforts of society. I think all of those words matter. Actually, clearly the science bit matters, and most of us are reasonably well trained in the sciences. So some of us are moderately well trained in the arts bit of it, but we could do better actually. And by art, I don't mean art and culture. I mean kind of the black arts of getting stuff done. We could do better in that space, and then organised efforts of society. So my boss frequently says, we do your pay and rations, Greg, and you're employed by the body called Sheffield City Council, but you're expected to be the Director of Public Health for the city of Sheffield and all that sail within that ship. Act like that. So it becomes around trying to organise what the city does to the better effect of the health of the population of Sheffield, taking into account the point about the health isn't the end point, it's a means to an end. So most public health, term used advisedly, isn't actually done by people who've got the term public and health in their job title. So one very obvious example, which is a thing of the moment in Sheffield, we've just implemented a clean air zone proposal, which is now live in Sheffield. It's been live for a week or two. The purpose of that is a very important bit of a wider strategy to clean the air. It's broadly accepted that everyone's got the right to drink clean water, and that's been well established for about 200 years or so. But the air that we breathe is dangerous to us. It's killing people. It kills somewhere between 250 to 500 people in Sheffield a year. So the work on that clean air zone hasn't been done by public health professionals. It's been done by officers within transport team, officers within the air quality team, obviously, officers who are responsible for where we put the cameras to measure stuff and how we actually implement the clean air zone. So my job in that one has been almost giving the reason and the purpose, because it is a public health thing. Clearly, it kills a lot of people. But I don't know the first thing about where one would site the cameras and how one would actually make a clean air zone work. So that's the bit about the organised efforts of society. Another example, we have a massively vibrant, in Sheffield and everywhere else, voluntary and community sector that do amazing things to support, promote and enable the well-being of people that live in neighbourhoods across Sheffield day in, day out, and so wide and diverse. I could nowhere near describe all of it, and I certainly couldn't do it pithily and succinctly. Some of that is directly funded by either me as the Director of Public Health or the local authority more broadly. Much of it isn't funded. Much of it's run by volunteers. And that volunteers, the clue perhaps isn't in the title. We need an infrastructure to support volunteers. That doesn't happen by magic. But that makes an enormous contribution to the well-being of the people that live in Sheffield day in, day out. It's not done by me. It's done by a whole bunch of people who don't have the word public and health in their job title and may not be even working in the name of public health, but a happy byproduct of it is healthier people, certainly people with better well-being than they otherwise wouldn't be. So, and again, my job in all of that, or my team's job, more to the point, is the sort of stitching it all together and making links and interfaces between different people, different constituencies, different professions, different organisations. Sometimes I have a very direct role in that, but more often than not, I don't. My job is kind of the behind-the-scenes orchestration or the conductor of it, rather than the player of all of the instruments. And that's quite difficult to describe to people. Back to what do you do for a living then? It's hard to describe all of that kind of succinctly and pithily, but that bit does matter. Otherwise you have less connected, less organised, and back to the organised bit of the whole of society, there needs to be an organiser in some of that. So sometimes that becomes my job.
No, I mean, to be honest, you're doing a fantastic job of explaining it. I mean, what an interesting, fantastic, almost entrepreneurial role that is, both of Director of Public Health and of the public health team more generally. I thought I might ask you a bit on how you navigate perception within and outside local authority and how that's changed through the COVID pandemic, because it struck me that, knowing people who worked within public health teams, I knew that they were under enormous strain. I knew that they were, the job was changing a huge amount. And, in examples like yours, it also became suddenly a much higher public profile role of, having to suddenly respond to media requests or to urgent developments. And on the other hand, the fact that, like you say, before the pandemic, people in the pub would ask you, what is it you do again exactly? Like that sort of public health as almost being the hidden partner in relation to healthcare. So I was just wondering if you could reflect both on, your experience of that as a team through the pandemic and what your reflections are for how public health is perceived.
So, I mean, I won't perhaps talk about pre the pandemic, but I'll give my frame of reference as starting from the pandemic. Probably late December 19, certainly into early to mid-January 2020, it was perfectly apparent that there was something big going on in Southeast Asia that was beginning to spread. So public health professionals were getting pretty twitched, actually. At the time, and still, the leading edge of that would be the organisation that was known as PHE then. It's now known as UXAR, and they have specialists who do this kind of emerging disease surveillance. And they were kind of sending, you're going to need to start to be worried about this. It sort of by late January, early February onwards, we were in full tilt. This is going to be a big thing. None of us quite anticipated how big it is, and there are some things that we kind of need to reflect on as we get through the inquiry. But it was perfectly apparent this was going to be a big thing. And as you say, for that two and a bit year period, it put the profession of public health, the role of the Director of Public Health and other public health professionals, but particularly the role of the DPH, smack bang in the middle of the spotlight, in a way that none of us were quite used to. None of us quite anticipated that. And as you say, lots of media, which was the visible bit of that, but also lots of behind the scenes stuff. And the role of DPH and their team during the pandemic in local government was partly CMO, local CMO type function, sort of being the chief scientific officer to kind of advise how we respond to the worst public health emergency that I hope any of us have to live through. It won't be the last pandemic. Let's be clear on that one. There will be others. There's no doubt there. But hopefully this was the worst. We will see. So partly our job was kind of local CMO type of job, being chief scientific advisor to the decision makers. The decision makers are politicians. Anyone that thinks DPH and or local authority chief execs are decision makers is mistaken. That's the point of local democracy. Decision makers are elected, not appointed. So there's a sort of a advisor role. Then there's a stitcherer togetherer role, because the response to the COVID pandemic was the organised efforts of the whole of society. It was an all-out effort by the whole of society, from NHS through voluntary and community sector, through pretty much all of local government, through to how we do and don't support local businesses, because no one wants businesses to go bankrupt in that process. So that was the organised efforts of the whole of society, and part of my job was the organiser and the orchestrator of that. Some things I had a bigger handle on than others. Clearly, I didn't have much to do with how we support businesses, but I did have a lot to do with the big P, big H elements of that. And then the last job, which came upon us during the pandemic, was the operational implementation on the ground. It was clear early on that we needed a stronger boots on ground public health response. Some of which a lot of which was done by the voluntary and community sector in Sheffield. Did a very, very good job, I might add. But that wasn't done because of it wasn't done in the name of public health. It was just done the orchestration of making sure that people didn't run out of food to eat in the first lockdown, for instance, was done largely by the voluntary community sector. Did a great job. We needed a bigger on the ground, big P, big H public health role, and we didn't have that prior to the pandemic. Our job was strategic in its nature, not operational and delivery. So government funded a pretty large local public health response, which became the responsibility of the DPH to supplement what then PHE, then UXAR did on the ground. So the DPH job was orchestrating all of that, and it was a very, very pivotal role during the pandemic. Coming out of the pandemic, the trick that public health professionals have got to pull off is, you do more than COVID then. So we're now back into the day job that I described further up in the podcast, which is the main functions of the local public health team. We're now back into that, but there's a bit of public consciousness that you lot do something to do with pandemics, don't you? And it's way beyond that. So we need to work on that. I think within public health and more broadly, we've kind of got that square now, but there's probably still a bit of public consciousness raising that we need to do around the sort of what the public health types do that isn't to do with infectious disease pandemics.
Well, that's so fascinating, Greg. I mean, what an evolution it has been, and then to go back into the day to day and try to think about how you can almost leverage both that experience and that higher level stitchering togethering that you've been doing for other health issues in the wake of the pandemic, and maybe using that elevated visibility. I mean, before we move on, I did want to press you a little bit on what I found to be, to my mind, a possible source of tension within local public health, which is that on the one hand, you have to be quite measured in things that you do, because you're working with local stakeholders, you're working with the budget that you've got to do the best that you can in very pragmatic, incremental ways. And, that is something that is very admirable. But precisely because of the importance of local services, of local communities, and of the importance of the things you're trying to stitch together, when you have long-term disinvestment in those things, like we've had, for example, in the UK over the past decade or so, that has large impacts on health that public health should find ways to bear witness to, if that makes sense. So how do you hold those two things in tension? Do you think there's a tension, and how do you think through those things?
Yes, there's a tension, and obviously the DPH is supposed to be the independent scientific advisor and all that kind of stuff. And no, who's truly independent? And there's a little bit of a point there, but I mean, the results with regards to the years of austerity on the health of the population are in, and they're not good. They're not pretty. The science is pretty clear on that one. Reread Mike Marmot's 10 Years On report, and Professor Marmot was very, very clear about that. It's probably a little bit more nuanced than that, and I know there are debates raging amongst academics on the sort of the actual sources of the now flatlining of life expectancy, healthy life expectancy. But that matters. Yeah, the fact is life expectancy and healthy life expectancy are flatlining, and that matters enormously to obviously our health, but matters to NHS and social care demand. It matters to a vibrant, productive society, vibrant, productive economy. So all of those things matter, and yeah, you just have to say it as you see it. We have got a much smaller state locally than we had a decade or so ago. That comes with consequences, and we have to deal with the hand that we've got, and do the best that the hand that we've got. There is something about yes, the size of the budget is smaller, but what matters is maximising what we've got. Obviously, all of us would like a much larger budget, but that isn't within our control locally. So we need to maximise the health outcomes with what we've got. More narrowly on the public health grant that pays for health visiting, school nursing, sexual health, drug and alcohol treatment services, the financial reality in macro terms is that it's 25% smaller than it was about a decade ago. Again, that comes with consequences. That's before you build in demand pressures. That's before you build in the cumulative impact of inflation over the years, and all of that kind of stuff. In cash terms, it's about a quarter smaller. We've got less health visitors, less sexual health clinicians, less drug and alcohol treatment investment than we did, and that will come with consequences. Well, it has come with consequences. We need to deal with that. But as you say, bear witness to that and say it as it is. And most directors of public health do that fairly openly and fairly plainly. That's just its straightforward financial reality.
Yeah, and related to this, I was wondering if you could talk about this in relation to the Association of Directors of Public Health, which you are vice president of at the moment. I mean, when I think of local public health, I think of directors of public health and their teams, and when I think of national public health, I think of OHID, for example. So where do you see the role of the Association of Directors of Public Health, both in advancing the incremental improvements to population health, and I guess making the case for public health more broadly with things like budgets?
So it has a few roles. I think one is probably fair to say that ADPH represents the voice of the Jobbing Director of Public Health. That's its job. It's a membership organisation. It should reflect the voice of its members. So its members are Directors of Public Health across the four nations in the UK. And we need to make good on the four nations bit. We're trying pretty hard on that at the moment. And that comes with complexity, because the public health system in England is very different to the public health system in Wales, Scotland, Northern Ireland. So but all up, our job of ADPH is to reflect the voices, views, and perspectives of jobbing directors of public health, how they see things on the ground in their patches. And I think we do a reasonably good job at that. Others can judge. We do often set out policy positions on issue X, issue Y, issue Z. We're doing a little bit of work refreshing all of our policy positions at the moment. So one that crossed my inbox recently was policy position on tobacco. And tobacco is the new tobacco. It still kills more people than most other things. So we broadly know what to do. Our issue in tobacco isn't lack of evidence, it's lack of resource, by and large. If we want to achieve smoke-free by 2030, or whatever year we've set ourselves, when we definitely should, we know what to do, and we can choose or not choose to accelerate that, and that's largely to do with the resources available to us. So that brings me on to the third role, is to advocate for the resourcing of public health. And let me see, 3 weeks before the start of the new financial year, I don't know what my budget will be to pay for the things that we really want and do a great job for Sheffield. I don't know what my budget will be
Wow.
for next year. I don't know whether or not inflation will be factored into that, and if it's not, we'll be making cuts to services. There's no fat left to cut. That was gone some time ago. So we'll have to make cuts to services. So and so ADPH does have a role in advocating for the appropriate resourcing of the services funded by the public health grant, as well as a sort of a policy and positioning kind of role. One thing that ADPH isn't is the national public health body. Is one of a number of non-government public health bodies, so a Royal Society and a Royal Society of Public Health and Faculty of Public Health, the other three. But there are plenty of others in the space of public health that maybe don't do it directly in the name of public health. So, but ADPH isn't the national public health body and couldn't pretend to be such, and hopefully we don't act as that. That has to be led from within government.
Oh, thanks very much for sharing that sort of insight into ADPH and where it sits in the wider landscape. I'm just still shocked by the fact that you don't know when the public health grant is coming in with so little time to spare, considering all the things that are reliant on it and the things that you've been discussing, all the different ways in which it influences health directly and indirectly. That's just quite worrying, isn't it? And hopefully that comes through, and it's just maybe a reminder both of the at times lack of support for this kind of work and a failure to acknowledge the significance of what cuts to it might mean in the future. It strikes me that one of the key roles that public health and local authorities can play, and something that you've written about in your excellent blog, which I recommend everyone listen to, it's sort of what I really like about the blog, aside from the insights in it, is the way that it's written. It's sort of very punchy and exact, but also stream of consciousness. It's like how I imagine, Liam Neeson's character in Taken would write a blog if he had a gun to his head. He's sort of like, right, well-being economy, right, number one, we got to do this. And then these lines of evidence come together and the three conclusions, 1, 2, 3, this is what we've got to do. It's just really sort of snappy and easy to follow and very practical. But one of the themes that you've come back to in the blog a few times is discourse and framing on health, and how important it is for public health to engage in that and to acknowledge the ways in which it's shaped. I was wondering if you could talk a little bit about your thoughts on that and where you see local public health contributing to that.
Sure. On the blog, definitely nobody's ever held a gun to my head. It's mostly the random musings of a bloke on a train. But sometimes more random than not. Anyway, to answer your question, framing really matters. One of the things I've learned over the years is that everyone seeks for the single big thing, the one big thing that will resolve all of that. And I think the big idea is that there isn't a single big idea. It's the multiplicity and lots of ideas. However, if there were one, it would be how reshaping the whole question of how we frame the conversation on health, taking the conversation away from individuals and the notion of personal responsibility, which is largely a failed policy framing over about 4 decades now, and away from the NHS. You read stuff in the public media about health, and everyone talks about the NHS. And the NHS, let's not pretend the NHS isn't spectacularly important and doesn't do amazing things. My middle son's only alive because of the NHS. So it does amazing things day in, day out. But it isn't health. The health system is the combined efforts of the totality of society. So for me in Sheffield, it's the combined efforts of local government, NHS, voluntary and community sector, faith leaders, business, pretty much everything that makes up the ship called Sheffield. So that's the health system. And I think if we can take our framing away from individuals towards populations and society, particularly the left behinds in society, and away from only being about the NHS towards the totality of health, and away from towards the structural determinants of health rather than the behaviours of individuals, that would be my one big thing. If I had one big ask, and that would make a massive difference. And yes, I have written about it. And as of you, I remember yours and others' BMJ editorial on the pollution of health discourse is one of the best things I've read for a long time. This stuff really, really matters because everything that follows according to the framing that we set. So it really matters that we get the right framing right.
Well, I completely agree. It's very kind of you to say about the article. I'm thrilled that it A, helped you to think, and B, appeared in one of the Greg Fell blogs. That's sort of like a big career highlight for me, that I was one of the, gun to the head bullet points. That was really good. No, I think you're absolutely right. And I guess part of the point of the pollution of discourse article was this idea that discourse isn't just something that's out there that exists. There are powerful interests that shape discourse, and a lot of research on the commercial determinants of health shows that to avoid legal liability, to avoid regulation, lots of different companies will sort of promote individual responsibility for harms and will dispute public health evidence related to their specific product and its specific harms. But there are these cumulative effects that these kind of things have. Yeah. And so I guess I wanted to ask you, you've really begun to engage in the blog and your thinking on the commercial determinants of health more broadly, how powerful commercial actors shape health directly and indirectly, help shape discourse and understanding. What do you think the role is for local public health teams when it comes to the commercial determinants of health, in your perspective?
So a few thoughts on that one. There is something about the role of DPH and their teams sort of shaping and framing the whole of the narrative in any given place. And that's a critical role for us. I'll come back onto that. It's clear that health matters for all sorts of reasons, as I've said. A pretty large proportion of the lack of health is non-communicable diseases, so heart disease, cancer, respiratory disease, etc. You go a little bit further back, and you're never too far away from the harm from alcohol, the harm from tobacco, the harm from gambling, the harm from other things that are the result of specific industries selling us products. And as you say, I think there's plenty of evidence that's been documented over decades by those that have studied the activities of what increasingly are becoming known as harmful product industries. They very actively shape and frame a narrative that health is about what individuals do. That infiltrates the public consciousness, and the public consciousness then infiltrates the process called democracy. And therefore, you get kind of status quo. You get no shift. That matters enormously. People don't make unhealthy choices, term used advisedly, very advisedly, in a vacuum. Someone's got to be the architect of the world. Someone's got to be the sort of the orchestrator and organizer of the to use the phrase that the behavioral insights guys use, the choice architecture. It's just a matter of who designs it, why, and in whose interests. And that the environment in which we live, the social, the commercial, the financial, the environmental environment in which we live, is heavily shaped and framed by the choices made by harmful product industries who want to sell us certain products. If there were no health consequences to that, fine, great. But there are health and environmental consequences to that, in the name of obesity and what that causes, in the name of alcohol harm and what that leads to. You take it a little bit further away in the name of climate. And we know that the activities of fossil fuel industries to delay significant regulatory action around fossil fuel regulation and or the way in which the companies act, that's led to a warming planet. We've missed the window of opportunity that we could have had. That matters. So shedding a light on all of that really, really, really matters. Then perhaps more practically, there are things that folk in my type of position do need to get right. There's something about shaping and framing how we take on this is the nanny state gone mad type of narrative. And there's plenty of that. So you kind of need to be able to respond to some of that in a local context. but also local government's an incredibly powerful machine. Democracy matters for all sorts of reasons, and local authorities are democratic institutions, but they're very powerful institutions. They have responsibilities around land use planning, spatial planning, environment regulation, licensing, which clearly matters to sort of gambling and or alcohol licensing, for instance. So have responsibilities around children's education, and so how can public health professionals work with those responsible for some functions that local authorities have to shape an environment that is rather more conducive to health than would otherwise be the natural path? So a very practical example, folk in licensing department might say, well, health has nothing to do with me. Well, alcohol harm leads to high blood pressure, amongst other things, many other things. High blood pressure often leads to stroke. Stroke leads to social care demand. And it's the social care bit of local authority where the demand pressures are eye-wateringly high, the costs are eye-wateringly high. That non-communicable disease that was related to alcohol harm is partly responsible for why local authorities are in a very, very, very difficult financial position. So the purpose of some of the functions of local authority very directly impacts on our health. So our job locally is to get some of that stuff right and get the right policy context and the right policy framing for a conversation about the health of the people of Sheffield or Wolverhampton or Walsall or wherever.
Yeah, absolutely. I'm so glad that you're thinking about these things and that you see an application of commercial determinants of health as a useful frame in the context of local government.
Very much so. Very much so.
I think that's really, that's wonderful to hear. And I know that there are challenges in doing this kind of thing, but it's great that you're thinking about it.
Yeah, there are challenges. So the two challenges, I guess. One is the sort of getting the public narrative on this stuff right. And Bite Back are an example of a group of young people that are doing amazing stuff on telling elected leaders locally in various parts of the country and nationally that they don't want to live in an environment that's saturated by junk food advertising everywhere they look, both online and kind of physical stuff, and shedding a light on the methods and tactics of harmful product industries to do what they need to do. They need to sell their products. They need to make a profit. They've got a responsibility to the shareholders. I don't think they're inherently evil. I worry about the consequences of what they do. So shedding a light on some of that changes the nature of the conversation, and people often feel quite angry that they feel they've been manipulated to purchase in the name of profit. And let's not pretend profit's not important. Profit is important. That kind of matters. But it's the consequences of profit, and it's the methods and tactics used by industry to maximize their profit at the expense of our health and our environment. That's the thing that really, really matters in all of this. So part of our job is shining a light on some of that. Part of our job is getting the narrative and the framing in which that exists right. Part of our job is working with colleagues in different bits of local government and beyond local government to sort of engineer the right kind of choice architecture that enables health to be the default choice.
Oh, well said. That sounds fantastic, and really exciting to see how actions around this develop, and what, because I can imagine there are lots of learnings that can be shared between local authorities as things are tried. That's all really fascinating to think about. Well, I wanted to end our conversation. This has been fantastic. Thanks for sharing your thoughts so candidly with a couple of questions that are more relevant for early career folks. And I guess first, because working in public health, for those who aren't in it, can feel really nebulous, and even the kind of stitching together type role you described, it in some ways innately feels less tangible and maybe less satisfactory compared to leaving a clinic or a ward tired at the end of a shift, changing out of scrubs, but knowing that you've seen the impact that you've had directly on X patients that day. So first, I wonder if you could share your thoughts on the satisfaction you gain from doing this job, and if you have any particular moments where you and your team kind of sat back at the end of the day and thought, you know what, that was a good one?
So even within the job, it's still quite nebulous and sometimes quite difficult to describe, as we've talked about. So looking in from outside must be interesting. I would say this is the best job I could imagine having. I can't imagine having a better job, and I have no clue what I want to do next. Zero clue. So I'm probably be in this job forever. So you're stuck with me for a while. Apologies for that. Um, the early career. Don't bite off all of the elephant all at once, as you and I have both talked about. This is public health is an enormous elephant. You could view it in some ways, depending on how you view public health. You could view it in some ways as an equivalent to medicine as a whole. Some folk view it as a specialty within medicine. You could say, well, it's as broad as medicine as a whole. And then you kind of add in a whole bunch of other stuff. So the kind of environmental health is broadly a public health thing. Health visiting, etc., is broadly a public health thing. So maybe it's even broader than medicine. For early career folk who are thinking about public health as a career, one, go for it. It's the best job I could ever possibly imagine having. But don't think that you need to be expert in all of the things within public health on day two, because it's just too big. It's taken me quite a few years now to develop a bit of expertise, and I'm still nowhere near black belt in any of this stuff. I'm merely a jobbing generalist that knows quite a reasonable amount around a fair amount of stuff. But don't think you need to know everything about everything all on day two. Get into it slowly. I know people that have come into public health from community development backgrounds and who now have amazing careers in public health. I know plenty of people who've come in from clinical backgrounds, ditto. I know people who've come in from teaching who now have an amazing career in public health. The route in doesn't matter. It's the aptitude and the training that you get when you're in there, and there are some things that we can improve our training on, but it's the sort of the aptitude and the ability to learn as you go, and then over time you acquire more and more skills, more and more competency, you get more and more experienced, and that gets you to positions like the one I've got. But don't think you're going to get there on day one. One thing that we do need to be better at is entry-level routes into public health. I think we're not very good at that. So we take people who have experienced careers in lots and lots of other fields, but it's the sort of how well do we do for people who do genuinely want to leave school being a public health specialist. We need to work on our entry-level routes into public health, because I don't think we're as good as we could be in that space.
And could I push you a bit on the satisfaction aspect, because that's something I've really enjoyed about this part of my career, which is working with people I really admire on things I strongly believe in. But there is an element of, there's an element of togetherness that comes with that. But I've often wondered what it's like in the local authority setting, especially when you guys are pulled in all different directions, and it's quite tricky, isn't it?
So it's harder. There's very rarely a sort of you get to the end of a particular day and think, wow, I'd saved X lives today, and that rarely happens. Sometimes when you've done a huge amount of work that led up to a big set piece meeting or a big set piece event of some description, and the event goes as planned, and that kind of would lead to a fundamental change in the course of some policy or other, or an approach to X, Y, or Z. That can be quite satisfying. That doesn't happen as often as we might want, but there's an individual event that happens from time to time, and that is satisfying, because you get to influence the leverage points on health, and leverage points kind of matter. But more frequently, it's when you take stock on a piece of work that you've done over a period of months, years, possibly decades. So, practical example, infant mortality is a really important priority within public health. 10 or so years ago, Sheffield wasn't doing terribly well, actually. Infant mortality matters an awful lot for all sorts of obvious but also unobvious reasons. The unobvious ones being it tends to be seen as a peak indicator for a lot of the wider work on child and adolescent health. If you get infant mortality right, you've got a lot of the other stuff right. So 10 years ago, Sheffield wasn't doing terribly well. We put our shoulder behind it, and we rewrote our strategy on infant mortality. We rechecked from what's the contemporary evidence base saying on the right things to do. How well are we doing the right things? Have we got the right depth, the right coverage? Are we doing the right things in the right way across our population? And we really put our shoulder behind the wheel for, so I think it was 8 pretty well evidenced programs. So safe sleep, breastfeeding, smoking in pregnancy, things of that ilk. 10 years later, we've halved the infant mortality rate and closed the gap. And credit to all those who made that happen, because it wasn't me. I was perhaps the orchestrator. There was an amazing number of people who made that happen across NHS, various local authority services, voluntary and community sector. And reviewing the point at which you review the strategy, you actually look at the numbers and you think, yeah, we've done some good there. So that's where you get the satisfaction mostly, rather than I had a great day today and saved X lives, because it's never quite that simple on a day-to-day basis.
Wow, what an amazing thing to reflect back on. That's quite incredible. And just one final question, something that's come through both in your blog, which again, I can't recommend highly enough, and in the way you've described public health generally and your role specifically, is in this sort of stitching together function, this combination of art and science, piecing together different things, different people, different organizations even. That requires, to my mind, a certain kind of mind and a certain kind of person. What do you think the qualities are that make for a good stitcher together in the context of public health?
So it does. It's probably the most important job for people of my ilk, is the ability to stitch together some things within So I sometimes describe myself, and I hate it, but I'm going to use it. The conductor of the orchestra, and I certainly don't know how to play all of the instruments in the orchestra. Some of the instruments are mine. No one's really interested in tobacco apart from the Director of Public Health. That said, in Sheffield, there are plenty of people who don't have the word public and health in their job title that do amazing stuff. The midwives do amazing stuff on smoking and pregnancy. The trading standards teams do an amazing job on confiscating illegal and illicit cigarettes, which is often linked to organised crime, modern slavery, etc. But that is mine. Tobacco control is one of mine, but air quality, I contribute to another party. So my job is the conductor of the orchestra. I know how to play some of the instruments, but not all of them. And I suppose in terms of the qualities that's needed to do that, people in my type of role can't micromanage and do command and control on all of that stuff. It's a path to impossibility. It's just impossible. There's too broad a range of stuff. There's too much a set of understanding. And if I tried, someone might say, "What are you doing, messing around with clean air? That's my job, Phil. Get your tanks off my lawn." And they'd be quite right to say that. I contribute to their party rather than control their party. So I can't do command and control on all of that. So the job is one of sort of orchestrating a complex system to achieve the goal, and the goal is better health and reduced gap. And of the two, I'd say the reduced gap is way more important than the better health. The job is to sort of orchestrate the complex system. So one of the guiding Bibles that folk like me have always had is the team of teams type of mentality. So the book that Stanley McChrystal wrote about the change in the US Army in the Second Iraq War, you can't kind of command that from the top. You have to just let people loose and let people free, and give them plenty of flexibility to act. Sometimes support them, sometimes leave them alone, and that's a sort of a skill that public health folk tends to have, and certainly is needed to be an effective operator in this kind of job.
Oh, that's super interesting reflection, and certainly just from my own perspective, something I've noticed both in you and in lots of other people I regard as extremely impactful and successful in public health practice is they do seem to have the ability to read the room, to understand where other people are at, what their agendas are, and where possible points of unity exist. And I think that is actually quite a rare skill, especially outside of that context in say academia. That ability to kind of read the room and sense where people are at and what the realm of the possible is in any particular setting is really important.
Agreed. You have to know where people are coming from. You have to know what drives them. So housing professionals probably don't really care that much about health. But if they get their job right, a happy byproduct is healthier population, less people live in cold, damp housing, all that kind of stuff. So know what drives different kinds of professionals, know what their sort of their reason they get out of bed in the morning, and help orchestrate the totality of the conversation to connect people together in a way that wouldn't otherwise happen. That's the key part of the job. But so yeah, in that context, reading the room and knowing the drivers that different people have and the motivations different people have and what their performance framework looks like, how will success in that world be judged or not judged? Having some insight into that is critical to be an effective operator in terms of the pulling it all together or the conductor of the orchestra.
Wow. No, that's brilliant. And I think a really useful skill and reflection to end on, Greg. Thank you so much for joining me on the podcast, and best of luck with everything that you're doing.
Thanks, Nathan. It's always a pleasure.
Well, that's it for another episode of Money Power Health. I hope you enjoyed this conversation with Greg Fell. I certainly learned a lot, and it gave me a lot of hope for public health in the UK in the future. If you have any ideas for future episodes, as always, please feel free to drop me a DM or an email. Otherwise, I look forward to catching up with you in future episodes, and I'll leave Charlie to sign us off. Take care.
If you enjoyed this podcast, please consider leaving a rating. It helps other people find it. The music in this podcast was by Daniel Manny. You can find more information about his music in the show notes. This announcement was read by the very talented Charlie Manny.